So do we have any question from the floor about the four topics that we have listened to? Any question from the floor? So can I ask a professor, for if you want to do the reconstruction with a primary hip replacement, what is your comment for the fixation of the cup? Do you prefer, is you think cementless, or some case you use the cage and the cemented cup? What is your...
So what we have to keep in mind that the prevalent fracture types in geriatric patients are anterior column and anterior column posterior hemitransverse. The head follows usually the anterior column. And this is basically the support for the cup. So this is one of the difficulties, that a regular cup in these fracture types cannot be used. This was the reason, that stabilization plus fixation was combined. If we have these atypical fractures, posterior wall, multifragmentary posterior wall, posterior column, then it's easier because, stabilization and fixation can be done through one approach. We have to keep in mind that the anterior column has to be stable to put a regular cup in. There are some solutions, with the stem cups, what you use for tumor surgery. This can be a solution, but these are very costly solutions. So we would not recommend this as a standard procedure. If you want to do combination of stabilization of the anterior column, then usually you have to rely on a limited stopper approach or something with one of those preformed plates, because they give you enough stability. But then, in addition, you have to replace the hip. We just talked about this last week at the National Total Joint Congress. It can be done through the anterior approach, but the majority are still doing this after repositioning of the patient with a lateral approach.
So the next question for Professor. In your experience, when compare between the acute fractures with the fixation, then replacement, and when compared with we use the anti-prototypical case, something like the Bert Schneider in acute fractures, then cemented PE. In your experience,
it's
better.
So if we want to go for secondary replacement, so this is how our thinking started in this, that we say, okay, we do something fast, limited, one operation, then wait until it's healed, and then go for also a smaller operation, which is a secondary total hip. We saw that 80% of the patients were doing well. So I think even little gaps and step-ups are better compensated in the geriatric patients. Not really good, but a little bit better than in the young patients. It's also depending on your experience in the reconstruction. If reconstruction can be done within 2 hours, it's something which usually can be done to these geriatric patients. But it's certainly something we have to keep in mind, that we should not threaten the patient's life. So still, with these fracture types, we can do it very effectively with a minimal blood loss, blood loss below 200 milliliters, and have an expectation of 80% of the hips surviving over the next 2 years.
Thank you, Professor. I have one question for Dr. Sutiwat. So you mentioned a few times about the EUA for the posterior wall fracture. Do you have any specific indication, or you do in every case? Or sometimes I have a case that is already reduced from another hospital, and I'm not sure about the stability. So can you have a suggestion? Because if you want to do another EUA, you have to take the patient to the OR, right? And then something like that. So do you have any guideline about the when do you want to do the EUA?
Is if there is a last fragment, maybe 20 to 25% is maybe affected hip joint reaction force. So this case, I maybe not do the EUA, but process to the surgical. But if some small piece or between the side and we not sure, and the clinical of the patient is very good, that I will do the EUA, because usually in my experience, if there is an unstable hip, the patient will say when I have moved a hip and he will feel some just like a subluxation or just like it's a nearly dislocation or not very comfortable. Yes, as the first case that show the EUA, because the patient after the growth reduction and the resident doesn't do the EUA, and then this between sides. Yes, but the condition of the patient is very good. But I want to make sure that there is no any subluxation, so I just do the EUA.
Just to be sure.
Just
Okay.
to be sure.
Okay. So maybe if it's big and you need the fixation, you don't need to do it, right?
Yes.
Okay. Thank you. One more question from Dr. Yanin. Dr. Yanin, you mentioned for the transverse, sometimes we have to go anterior, sometimes we have to go posterior. Is there any special circumstance you need combined approach, or maybe the more extensive approach such as a surgical hip dislocation? What is your comment?
I think it depends on the associated injury. Most of the time, I can claim that simple transverse fracture from the posterior. Sometimes the fracture orientation is not like a short oblique, it's quite long oblique. So it's quite hard to get the anterior column reduced. So at that time, I think this is the appropriate case to fix just only posterior column and turn the patient supine to do anterior. Sometimes it depends on the fracture orientations. Yeah. Another thing is if there is some combined like a SI joint or pelvic ring injury, that we have to go to the anterior. That associated with the posterior wall, something like that. For sure, this is a combined approach. And other than that, I think it's usually go as prone position with the Coker and base. So it's important to scrutinize the fracture configuration, see the X-ray and CT scan.
Okay. Okay. Thank you. Thank you very much. Okay. I think one more last question for Dr. Teshit. Your lecture is titled Intrapelvic Approach for Beginner. But after I see all the important structure in your lecture, I'm a little bit afraid. So I think maybe can you comment in which case that is suitable for beginner and for the stop-by approach that you would recommend if many young surgeons are sitting here and they want to start doing the stop-by approach, and which case you should avoid for this approach?
Okay, so first of all, since the intrapelvic approach is becoming the staple of the anterior approach, replacing the medial window of the ilioinguinal. So I would say it's suitable for the fracture of the pelvis that need the fixation in the anterior ring, and also some of the fracture that is reducible in the anterior approach. I would say I would be careful in the late case or in the case that have the injury of the bladder that would contaminate the surgical incision. For the beginner, maybe the fracture of the rami that is lateral enough that you have to go over the brim so that you can put the plate and have enough fixation of the screw, not just the fan and steel and with the symphyseal plate. I think that would be the simple case that they can try. Okay, so late case may be a little bit tricky because the fracture callus would adhere to the soft tissue and make it difficult to dissect. Also, if the fracture is in the area of the beneath the external iliac vessel, I would be really careful trying to go below. So because we have to lift all the structure and we can injure it unintentionally.
Okay. So thank you very much. So I think we had a very good session with excellent lectures and some good questions. So I thank you all the speakers, and I thank you everybody for your participation.